Good afternoon. Welcome to our HeartTalks webinar on understanding health disparities in heart disease in these unsettling times. The confluence of the coronavirus pandemic and the current national discussions on race and inequality in the United States serves as the background for our webinar today. For the next hour, we will learn about health disparities for women with heart disease and how the social determinants of health impact health outcomes. We are joined by Dr. Heather Johnson from Boca, Raton. Dr. Johnson is a preventive cardiologist at the Christine E. Lynn Women's Health and Wellness Institute of Boca Raton Regional Hospital and Baptist Health, South Florida. Before Dr. Johnson starts, I'd like to invite all of you to submit your questions using the Q&A button at the bottom of your screen. We will come back to them during the discussion portion of the webinar. Without further ado, Dr. Johnson, please take it away.
Thank you so much, Selena, and thank you to Women Heart for the opportunity to talk as far as really highlighting this important issue. And before I dive too deeply, I just want to stop and say hello to our Women Heart support group right here at the Lynn Women's Institute, and thank you to those who are tuning in virtually. I really appreciate it. And also, I'd like to tip my hat to all the Women Heart champions across the country. I thought that this slide was very appropriate as far as to start with because of the fact that it highlights the racial, ethnic, and geographic diversity that has really defined Women Heart, and also the growing support and outreach to our communities. And with that, we'll move forward to the next slide. So for Women Heart and also for women overall, we still have some work to do as far as heart disease being the #1 cause of death, but how women as a group, there's still a bit of a lag as far as awareness, prevention, and treatment of heart disease compared to men. And so the mission and the goal really highlights the fact that as women, there are things very different as far as how we may present with heart disease, our journey and our path, but also understanding that there are some differences across race and ethnicity that also define some of those risks. But overall, compared to men, unfortunately, women are still less likely to receive information about their own risk for heart disease. I've had some women share with me how they'll go to the doctor with their male significant other, and the information may be different as far as what things are even discussed as far as heart disease or not compared to male versus females. It's also interesting to highlight that women are less likely to be started on medication or even have treatment intensified to appropriate therapy for management of what's called atherosclerosis or plaque in the arteries. Unfortunately, also women are more likely to have a heart failure diagnosis missed or delayed, where it may be considered heartburn or postnasal drainage or something else other than identifying heart failure. And this has led to women being diagnosed later along the heart failure journey and having symptoms a lot longer. Go on to the next slide, please. As we think about heart disease, yes, heart disease is the #1 cause of death when we look across males, females, and all race and ethnicities within the United States. However, the term heart disease is really a much bigger umbrella term. And you see below where I began to list so many different things that fall under the umbrella of heart disease. So we may think about heart attack, stroke, bypass surgery, heart stents. But then there are also valve disease, abnormal heart rhythms, peripheral artery disease in our legs, cerebrovascular disease when we talk about stroke or plaque in the arteries. There are also genetic or hereditary factors, different types of heart failure. There's so many different things that define heart disease. And so as we come together to tackle this, we have to understand also that everyone comes with sometimes a little bit of a different diagnosis of what it means to walk with the diagnosis of heart disease. Next slide. So when we look at the impact of heart disease across the United States, this is one of the first slides that breaks things down as far as race and ethnicity and also males and females. And I don't have the ability to personally use the pointer, but I'll describe it as we go along for each of the slides. If we notice that top purple bar, African American or Black females are more likely to be affected by heart disease during life, and also African American or Black males, approaching between 44 to almost 48%. And again, this is not just heart attacks or strokes, but heart changes because of high blood pressure, heart changes because of abnormal relaxation and vessel disease. This is then followed by white males and then white females being affected within the United States, approaching about 34 to 38%. And as time goes on, we're expecting close to 40%. And then followed by our Hispanic and Latino males and females, just around 30%. And I'll highlight different race and ethnicity groups as we move forward. You'll also hear me use various terms because I try and have a bit of a broader definition and use of terms, understanding variability across the country. So right here on this slide, we begin to see that heart disease, as far as who's walking with it and dealing with it on a daily life, affects African American females a lot more compared to our white and Hispanic Latino counterparts. Next slide. All right. So when we talk about race and ethnicity differences, as far as women who are walking with heart disease, if we think about even our women heart support groups across the country, it's important to highlight that our Black or African American women actually have a lower length as far as life. As far as Black women may have 3.4 years shorter lifespan than white women. And that's unfortunate because of the fact that means earlier deaths due to heart attack, sudden cardiac arrest, heart failure, and stroke. It's also important to understand that women are more likely to have sudden arrest or cardiac arrest or sudden death due to heart disease before even realizing they have a diagnosis of heart disease. Also, in addition to a shorter lifespan, Black women are more likely to have what we call risk factors or contributors to heart disease develop earlier in life. So for example, Black women are more likely to have high blood pressure earlier in the 20s or even teens compared to our white or Hispanic Latino counterparts. Also more likely to have obesity and diabetes. Sometimes there have been discussions about access to care, medications, and there have been a lot of research that shows that even if access is equivalent, the medications are exactly the same, everything being equal, some of the medications are actually less effective in Black or African American females. It's also important to highlight that race and ethnicity differences as far as shorter lifespan, earlier risk factors, and even medication efficacy or effectiveness differences can still vary despite socioeconomic status. So if you look at middle and upper class socioeconomic status, unfortunately, Black women are still more likely to be affected by heart disease and earlier death due to heart disease compared to white women. And these are the stories that we're hearing around the country, and why we want to make sure that we highlight not just the definition or heart disease, but everyone's journey as far as different burdens related to heart disease. Next slide. So we're going to break down hypertension or high blood pressure a little bit more, and this is data up until 2018. There are different bars here, and I'll walk you through it. So what would be on your far left here, the cluster of bars as far as all? That is males and females across race and ethnicity. And notice in the middle, as far as that blue bar, 57% as far as Black or African Americans have high blood pressure, compared to the darker blue bar, non-Hispanic white, and the lighter blue bar on the other side as far as our Hispanic or Latino population. Now, with that being said, it's still well over 40% for the other race and ethnicities, but Black or African Americans lead as far as, unfortunately, the burden of high blood pressure within the country. The middle section there are males. And again, non-Hispanic Black in the middle, 57% as far as non-Hispanic Black males having high blood pressure. But also notice, as far as non-Hispanic white and Hispanic Latino males, at least 50% having high blood pressure up until 2018. Then further the grouping over to our females. And unfortunately, as far as our Black women, very similar to Black males as far as leading the pack of who has high blood pressure in the country. We think about the effects of high blood pressure, earlier risk of stroke, heart failure, kidney disease. And so these are some of the things that begin to add up when we talk about the burden of heart disease beginning to affect our racial ethnic differences across the group and greater within our Black or African American communities. Next slide. Now, I also want to highlight again that there's been a lot of efforts within the community to make our Black or African American populations aware of high blood pressure. And what they've realized is that even with higher rates of awareness and higher treatment rates, Black or African Americans actually have the lowest rate of achieving what's called hypertension control, or whatever that goal blood pressure should be for them. And that's a very important point because it lets us know the education is getting out there, some medications are being started, but from the medical community or clinical community, we're learning that there are just certain differences as far as how the medication may respond, or even what's maybe called resistant hypertension, where it may not necessarily respond as easily or resolve as far as to where we want that goal to be with blood pressure medication. Next slide. So we're going to move from high blood pressure to obesity. Again, just kind of an overview throughout this talk. And this is data from 2017, again highlighted, and we'll talk through each of the groups here. So for our total population, men and women across race and ethnicity on our far left side of the groupings, we see obesity rates. And the blue bars we see are non-Hispanic Black population, and then the darker brown bars, as far as that 47%, are Hispanic or Latino population. Notice the race and ethnicities that are leading as far as, unfortunately, highest rates of obesity here within the United States. Our non-Hispanic white population approaching 40%, and our non-Hispanic Asian population around 12%, but we're going to discuss that a little bit later. It does not necessarily mean that they're protected from heart disease. In the center, we have our male population. Notice again, as far as higher rates that we may see among certain race and ethnicities as far as minorities, but non-Hispanic whites are pretty similar as far as non-Hispanic Black males as far as rates of obesity within the US, where Hispanic males, unfortunately, 43% are considered obese. And this definition is basically a body mass index of at least 30. So you may hear your BMI or body mass index is a certain number, and that's how they begin to categorize who may be overweight or obese or other categories. Now, on the far right side is our female, our women within the United States. And I just want you to sort of look a little broader here and notice that women in the United States across all race and ethnicities have higher rates of obesity than our males in the US. And unfortunately, this is an example that as women, it's a lot harder to take care of ourselves and self-care, trying to find time to exercise and take care of our family members and our community and the jobs and all the other responsibilities. Where unfortunately we see that when the non-Hispanic white population, almost 40% of women are considered obese. Our non-Hispanic Black population, 55% obese, 14% non-Hispanic Asian, and again, just crossing 50% with our Hispanic Latino population. So as women, this is really a wake-up call when we talk about not just our risk for developing heart disease, but also our risk as far as progression of heart disease or having recurrent events. And so again, walking through different causes of heart disease, walking through what some of those risk factors are, and how do we make sure that we continue to focus on these things even after we may have been started on medication or may have had a diagnosis. These are still important factors. So women, we definitely have our work cut out for us when we look at these numbers. Next slide. So this particular slide is just an overview as far as a list. When we talk about risk factors or contributors to heart disease. And on the left side, there may be a term that's used as far as more traditional or things that we're more familiar with: diabetes, smoking, weight, overweight or obesity, physical inactivity. And it doesn't mean that you're busy around work, but really dedicated exercise. high blood pressure or hypertension. And the term dyslipidemia can mean high bad cholesterol, low good cholesterol, or some other factors. Along that other side of the heart, that right side where it starts with preterm delivery, we're beginning to really highlight the fact that there are certain risk factors or contributors that are more unique to women. So again, with Women Heart, we are focused on all of these risk factors, but along with Women Heart and many other organizations, the goal is to begin to highlight that women really are different as far as how we may develop heart disease and contributors. Pregnancy is a very, very important fact because of the fact that preterm delivery or earlier delivery, disorders regarding hypertension related to pregnancy, which I'll touch on in just a bit, and gestational diabetes or diabetes that begins or develops during pregnancy are key factors related to pregnancy that can increase a woman's risk for heart disease down the road. For autoimmune disease such as lupus, much more common in women and also much more common as far as in Black or African American women. This lists breast cancer treatment, and I also want to highlight the fact that here at the Lynn Women's Institute, we work very closely with our Lynn Cancer Institute, and we understand that breast cancer, as far as having a diagnosis itself, also is a risk factor for having a future risk for heart disease. Treatment is not just chemotherapy as far as increasing your risk, but radiation therapy can also increase your risk for heart disease. The other thing is that we notice is that women who undergo chemotherapy, particularly who have Ashkenazi Jewish ancestry, may have an increased risk of heart damage related to chemotherapy. Depression is listed, in addition to prior trauma and other mental health exposures or conditions can also increase someone's risk for heart disease. So now our discussions when we're doing our preventive visits go beyond smoking and blood pressure, but have to address so many other factors when we're looking at a woman's risk factor and journey as far as heart disease. Next slide. So this is part of an infographic from the Preeclampsia Foundation, and just very briefly, but preeclampsia is a disorder that develops during pregnancy, usually late second, earlier third trimester, that can still even present early in the postpartum period. And it's basically when there's an abnormal blood pressure elevation associated with protein in the urine. It can progress to other disorders such as eclampsia. And the fact that someone may have a history of it during pregnancy, even if they have a healthy childbirth, etc., the fact that someone has a history of it during pregnancy increases their future risk of heart disease. So it can double your risk of heart disease in the future, and you're 4 times more likely to develop high blood pressure later in life where you have persistent high blood pressure. And it says 5 to 8% of pregnancies, but when you think it's really 1 in every 12 pregnancies that women can be affected by some spectrum of this disorder, it's a pretty significant factor that we have to keep in mind. It also increases risk as far as not just heart events, but it really raises that risk as far as 2 out of 3 women with a history of preeclampsia, unfortunately, are more likely to die from heart disease. So again, we're not just knowing that history, but how do we monitor the blood pressure? How do we make sure that the blood vessels are healthy? And so these are key things that we're beginning to focus on more and more. And right here at the Lynn Women's Institute, we do have a program in which we're focusing on women's postpartum health to look at blood pressure and other risk factors. Next slide. So when we look at how preeclampsia can affect various race and ethnicities within our female population here, not only can preeclampsia be the presentation of blood pressure and getting that diagnosis, but unfortunately it can lead to events such as stroke and heart failure. This is just the stroke data. And you can see that Black women who have preeclampsia are about 3 times more likely to have a stroke. Hispanic or Latino women, at least 2 times more likely to have a stroke with preeclampsia. And I also defined, this was a research article, both their abstract and full paper, and they had a category called all other women. Still almost double the risk as far as risk of stroke compared to white women. And notice Asian Pacific Islanders, our Native American females, our mixed races, etc. And so it's a lot of different racial ethnic minority groups that are affected by preeclampsia as far as very serious conditions such as stroke. Next slide. And then there's heart failure. Notice as far as the risk, almost 5 times, almost double the time, up to 60 deliveries, per 100,000, 60 per 100,000 deliveries, double the risk of heart failure. As far as Black females presenting with heart failure with association with preeclampsia. It's very, very unfortunate. Again, also seeing our Asian Pacific Islander, Native American women also affected greater than our white females. When it's all said and done across all race and ethnicities, you can imagine as a new mom, yes, there's preeclampsia as far as high blood pressure and close monitoring and the concern as far as during delivery, but then the unfortunate events of stroke or heart failure at the time of delivery just really makes things extremely complex and just the increased burden. And this then is a risk factor as far as other heart events or vascular events down the road. So there are a lot of things going on as far as a focus with Women Heart and other national organizations to really bring this to light and say, how do we begin to decrease not just the risk for preeclampsia, but stroke, heart failure. And then also we have to address, go ahead, the next slide, please, deaths during pregnancy. Unfortunately, if you look at this slide, it starts at 2007, it goes through 2016, and you see a very, very similar pattern. The dark purple are our Black females, and that light purple just underneath it are American Indian, Alaskan Native women. And you're seeing the fact that you see double, triple as far as risk of death across these racial ethnic minority groups compared to other groups. And I can tell you the 2018 and more recent data has not changed. So we have quite a bit of work to do, not only as far as stroke, heart failure during pregnancy, but maternal deaths. And you can just imagine the impact on families and communities during these times. Next slide. So this is an interesting slide from the American Heart Association. And what they've done is that they've broken down death from heart disease, all causes. And they looked back as far as 15 years, and it's all causes across race and ethnicity. And notice just globally, you see a bit of a downward trend, and then it's beginning to level off. And I can tell you that even in the most recent years of data, that plateau has continued, and in some has begun to increase a bit. So we're beginning to lose that benefit we were seeing as far as death rates from heart disease going down. However, over time, you notice that the curves stay pretty separate, in which at the top here, you see the gray as far as Black or African Americans within the United States having the highest rate as far as mortality or death from heart disease in the United States. The yellow as far as white, non-Hispanic population. The orange at the very bottom, you see our Asian Pacific Islanders, and then you see Black and Native American more in the middle. Go ahead to the next slide. Now, what's been highlighted is the fact is that for our Hispanic Latino population, we want to say that even though those curves are a little bit lower, heart disease is still a major cause of death, but also our Hispanic Latino population is more likely to die from complications related to diabetes, in which you're looking at also kidney issues and multiple other factors related to diabetes. And so it's not that the rates are lower and so it's not as serious. No, it's very serious. And we realize we still have to tackle those risk factors that can affect people's lives, quality of life, and mortality. Next slide. And then there was also a paper put out by the American Heart Association as far as with our Asian Pacific Islander population, particularly highlighting our South Asians, as far as Asian Americans, and unfortunately higher risk related to diabetes and cholesterol abnormalities. And even though the slope is smaller as far as what we're seeing as far as rates of death due to heart disease, unfortunately, there is a concern that we're just not capturing the real burden as far as heart disease within the Asian community. But then also what's been well documented is that unfortunately Asian Americans are more likely to have heart disease younger in life. And so although you may not see the same high blood pressure or obesity rates, it's still affecting the vessels very seriously. And we're continuing to learn about all race and ethnicities as far as how heart disease develops. Next slide. So the past few slides we have really talked about or I've discussed rather, the fact that there are different pathways and journeys that each race and ethnicity has to address as far as risk factors. Across all communities, though, it's also important for us to address what's called social determinants of health. And you may have heard the term. Selena also talked about some of the social discussions and issues that are being raised now more than ever. But from both a medical community and also throughout our support groups and through Women Heart, these are things that we're focused on, and this is beyond just a diagnosis or medication. And I'm just going to touch briefly on each one. Number one, economic stability, and stability is a very key word. Unfortunately, I'll touch a little bit more on COVID-19, but COVID-19, as each of you know, has impacted everyone's life. And it has affected jobs as far as job loss or unemployment or underemployment and, you know, expenses, debt. And when you're trying to figure out as far as what bill to pay or what bill cannot be paid, it makes a big difference on your health. Neighborhood and physical environment, the next section. There's discussion about housing and transportation. Unfortunately, some neighborhoods are not safe for people to go for a walk in the community. Going for a walk is unfortunately not necessarily even possible, just depending on the layout of the community. Parks are predominantly closed. Transportation was affected throughout COVID. And if you look back at the economic part and think about housing, there were pauses on rent and certain mortgages because of the financial impact. Well, even before COVID, these are important things that we have to discuss with our community members and our patients when we're trying to figure out how can we make sure that they have good quality of life. Also, education. And that's beyond what year we were in school or we finished school. It's also related to health literacy. Do we understand the information, the medical information that was given to us? Do we understand the diagnosis, the medication? Was it explained in a way for us to be able to understand? Was it explained in the appropriate language? Also think about, for example, education and early childhood education or just childhood education overall, elementary, high school. COVID-19 and other challenges in life can definitely disrupt education. And that's important also regarding social support. Food is an important factor. We talk as far as the importance of a low-fat diet or low-sodium diet. However, what is the source of that person's food? Do they have a regular source of food? I'm very grateful for certain community efforts that are going on to make sure that people can have access to certain food even during these typical times. But we have to remember it's a lot easier for us to say, pick a low-sodium diet, but we have to think about, does that person have access even to low-sodium food? Community and social context. There's been a lot of discussion about communities and discrimination, and all of that adds up to stress of their daily life. It can definitely affect blood pressure, it can affect heart rate. And so that's one of the reasons why Women Heart wanted to bring this discussion in along with the social determinants of health and heart disease, because it's beyond just the medical terms or medication or exercising, but just how we are in the community and everyday life that also has an effect on our health. And the healthcare system. You know, are you able to reach your providers? Was telehealth, do you have access to telehealth when the clinics were disrupted due to COVID? Are things being explained that support also and take into account your culture and your beliefs and quality of care? And so when we talk about health outcomes in the orange at the bottom, it's not just death or mortality, but your quality of life. How many days are you able to really make and have options to heart healthy steps and heart healthy food and exercise and what's possible? And unfortunately, even before COVID, this was very challenging in a lot of communities, particularly racial ethnic minority communities. We have not begun to talk about our rural communities or homeless population, but there's a lot of factors out there that we have to address across our country. Next slide. So this was a statement from the CDC. It's focusing on coronavirus, and it's also known as COVID-19. And to quote, it says, long-standing systemic health and social inequities have put some members of racial and ethnic minority groups at increased risk of getting COVID-19 or experiencing severe illness regardless of age. Next slide. The statement really highlights what we've been seeing nationally. This slide goes up to June 6th. I also know more recent data was out on June 15th. But it looks at COVID-19 associated hospitalizations by race and ethnicity. Notice our American Indian, Alaskan Native population has been hit hardest as far as hospitalizations due to COVID-19, followed by our non-Hispanic Black or African American, and then our Hispanic or Latino population. You keep going, then we also have non-Hispanic, Asian, and Pacific Islanders. So these are the hospitalized or hospitalizations represent more severe disease. These are also people as far as disrupted from the community, their family, and it's really has a domino effect as far as this particular pandemic on everybody's life. And so unfortunately, these also we have learned, go ahead, next slide please, that having a history of heart disease, asthma, diabetes, obesity, definitely increase your risk, not only of contracting, but really having severe symptoms and or death from COVID-19. So if we use COVID-19 as an example, especially for social determinants of health and also with heart disease, unfortunately, individuals or families who may have lower income, job loss, underemployment, you can't talk so easily about flexible work schedules or working from home. Some do not have paid leave or very limited paid leave as far as childcare and educating their children virtually. We talked about difficult financial decisions that are even harder now, higher stress, limited options for self-care. Unfortunately, that has resulted in people being unable to pick up their medication. Telehealth is not always an option for everyone, depending on their computer or device access. And so again, the same way with COVID-19 is with high blood pressure, diabetes, obesity, and heart disease management. We have a ways to go as far as making sure that everyone has access and is able to achieve as far as the quality of life, regardless whether or not they have heart disease or other risk factors. Next slide. So in summary, I know that was a lot of information, and Selena and I were going to digest it a little bit more for you in conversation. Heart disease is the #1 cause of death among all women and men across race and ethnicities in the United States. But what we've learned is that risk factors such as high blood pressure, premature earlier death from heart disease, and pregnancy-related deaths and unfortunate conditions are highest among minority populations, particularly our African American and Black communities. Also, racial ethnic differences continue even after you take into account socioeconomic status. We see gaps as far as in our middle and higher income levels. And overall, to really wrap this together, it's that although we have our risk factors from diabetes, pregnancy-related, lupus we talked about, breast cancer, putting all of those conditions together within the context of social determinants of health, food access, community support, cultural relevance, all of that makes a difference as far as being able to understand, not just individually and also with our providers, but as a community and in our support groups. And then as we move forward with Women Heart as far as how to begin to address these things, will hopefully help to decrease the disparities, not just for heart disease, not just for COVID, but also other conditions. And with that, I'll say thank you again and welcome back, Selena.
Thank you so much, Dr. Johnson. I was taking notes during that time, and there's so much information, and it's really packed in there. And so for those of you who might be interested in getting the slides, we will have them available on our website after we're all done here. But I really want to thank you for bringing up, the social determinants of health, and also highlighting the need to address these particular disparities in communities of color. And I just wanted to take a few seconds to highlight a few of the things that Women Heart has been doing for years and years and years. We participate in 29 Days of Heart, which is a social media campaign focusing on heart disease in African American women. We have a lot of activities around Hispanic Heritage Month, and and a whole host of kind of campaigns and activities that are focused on specific communities. But I will tell you from my experience and having now been with Women Heart for 1 year, the most powerful thing that we do is bringing women together, as you rightly say, from all walks of life, from all communities across this country. And so I'm glad that you started with that picture of champions, because I think for anyone involved with Women Heart, that training and that time spent at the Mayo Clinic all together, seeing not just the diversity in different races and ethnicities, but also in age and in profession and in language. And for me, Women Heart is the epitome of the whole is greater than the sum of its parts.
Right.
And I think, talking about those various social determinants, the thing that really stood out to me was social support. And that is at the top of the list in terms of what Women Heart offers. So with that, I wanted to ask you, in terms of the experience of Women Heart champions in Boca Raton, what sort of impact have you seen in women who have become part of Women Heart as champions? How have you seen a relationship between perhaps their participation in Women Heart and their own health outcomes?
Great question. The beautiful thing about it is that, as far as our Women Heart champions, not just as far as making sure that their health and their self-care is really number one, but how much they reach out as far as to other members in the support group. And what's been wonderful about the group, and kudos to Robin, who's socially distanced down the way here, but is that we have tried to follow the lead of other Women Heart support groups, and hey, let's launch virtually. Mm-hmm. Let's be able to allow people who have access, who may not have been able to even come at a particular day or time physically, now have options as far as virtually. Mm-hmm. And our Women Heart champions has been phenomenal, not just as far as health, but also that support. I try and get to certain events a little early, and pre-COVID, welcoming people as far as hugs and smiles, and asking truly questions, knowing how are you, and giving people time to be able to talk, not just as a support group, but just individually as far as building bonds that are really led by our champions. And we were joking about, no matter what the event is, if Women Heart is there, we're always wearing red, and we're proud, and we stand tall as far as with our champions who have really, really made a huge difference. And the Lynn Women's Institute here is just such a welcoming community, because where people are meet, it's not about illness or it's about health, it's about wellness. It's really about, this is your time to take care of you, and hopefully reach out and take care of others too, as far as you bring that information to the community.
That's wonderful. If you had a wish list for organizations like Women Heart and other patient advocacy organizations out there, what more do you think we can do to address these disparities, to lessen what we see as a real outsized effect and impact on communities of color?
So this is great, and I know you and I were going to kind of bounce some things back and forth. One of the things that we've realized, and it's come to the forefront even more, is the fact that great discussions that we have, either as a support group or different events that go on, it's a bit harder for, particularly when we're talking about Women Heart, our women who are maybe working during the day, do not have access to be able to break away, and we feel as though we're missing other parts of the community who cannot break away and say there's a webinar at 2 o'clock Eastern, or can't break away pre-COVID as far as to an event that may have been, even if it was after hours, 5 o'clock is, especially if you have children or other responsibilities. And so how can we be more creative to make sure that our outreach methods able to help people regardless of their schedule and other responsibilities, and this way we don't feel as though there's part of the population that's really missing out just because they had other responsibilities there.
That's great. And it's in some ways, I have been repeating this statement for months now. None of us would ever wish COVID on ourselves as a global community, but here it is. And I think that we as an organization looking after patients, and that historically has happened face to face for the most part, we've had to pivot. And to your point, we've had some great successes in getting our Women Heart champions to run their support groups virtually. I mean, I'm very pleased to say that as of yesterday, I think our tally was 31 support groups are now running virtually, which is phenomenal. And we will continue to encourage more of our champions to run their support groups virtually. But to your point about access, and one of the ways that we can help to address some of these disparities is to make access to our programming as open as possible. The internet and sort of the virtual world really provide us with a new and important opportunity for that expansion of access. And so my kind of goal is that we have, symbolically, we have 40 virtual support groups, because in theory, what that means is we could then almost have virtual support across the week. And so instead of support being given geographically, it could be based on time, when you're available throughout, in the day. And so the fact that we have 31 means that we've got a really great starting point for the possibility of that kind of access. I guess the other question is, looking at, and I'm going to start to get to some of these questions, going back a little bit to the fact that these disparities are borne out in research. Mm-hmm. One question that I have that's sort of connected to another question that I have is, have studies been done to really understand why African Americans are at higher risk for heart disease? And so that's a question coming from Wanda, but I guess that's sort of connected to, are there ways that our programming could also consider reaching communities of color beyond, let's say, the traditional ways of outreach that Women Heart has been known to do?
No, great, two great questions. And Wanda, that's a wonderful question. The American Heart Association has really highlighted, they have basically statements or scientific statements that have beautifully summarized the literature as far as the more up-to-date literature, and even some historical publications as far as why heart disease rates are higher in African American and other racial ethnic minorities too. And so that's why I actually had the pleasure of meeting Celine at one of the American Heart Association scientific sessions in November last year, pre-COVID. And so we're high, and also the effect of heart failure on women. Mm-hmm. And so we're learning that, unfortunately, when we talk about diabetes and high blood pressure and obesity all contributing to developing heart disease, unfortunately, our African American women, 50%, as far as when we look at high blood pressure already, and especially longer in life, having it starting earlier, that can definitely increase risk a lot faster and be more severe in the African American community. Mm-hmm. As far as with outreach, one of the things that I've heard from women in general across race and ethnicity is just being able to have time to really ask their questions that's pertinent to their health. It's one of those things in which we've realized that people want to know in general as far as what their risks are and what their conditions are. But a lot of times, time itself, the clock, things are very limited, and there's just not that time to be able to devote and be open as far as what those personal concerns are. I have to say here, and I've seen this across the way as far as in other geographic regions of Women Heart, is just being able to have that open dialogue and just say, what's on your mind? What would you like to bring up? What do you want to talk about? What are some things that you're concerned about? And I think as we work very closely with our clinical and medical colleagues and across health systems, how do we make sure that there is time not just to ask about the social determinants of health, but their own personal worries and how they even assess themselves as far as being at risk for heart disease?
Yeah.
And so we may notice that sometimes the risk may be stroke and not heart attack, but that relationship and how those risk factors actually overlap may not be understood. So there are a lot of different angles that we can definitely take, but we are learning that just people being able to have time to learn, but also ask in their own social and personal context makes a big difference.
Mm-hmm. Mm-hmm. Yeah, and certainly in the discussions that we've had with champions, the champions themselves are incredibly innovative about how to reach their communities. And we've had folks who wanted to do outreach in their church community. Yes. We've had other champions who wanted to do outreach in their book clubs or their salon when they have their when they go and have their hair done. So I think that these are the Women Heart, I think, is really getting to a place where we want to be where the women are. Yes. As opposed to and again, this is, I think, an opportunity that COVID presents to us. Many of our programs have been historically based out of hospitals. Well, a lot of these ancillary activities in the hospital setting right now are not happening. Right. And so, so we have to sort of get creative, because whether or not there is COVID, we still have very deep needs for connection. And so, I guess I also want to make sure that what we are underscoring here today is that Women Heart continues to be here, understanding that we have these needs for connection. And as Dr. Johnson spoke about, that connection and social system is just as important a part of somebody's thriving as healthy food and exercise. And so, to the extent that Women Heart can be, can support women's ability to connect with one another, I think that's really important. Let's go to a few more questions that we've got come in. From Kelsey, she says, what can we do as advanced practice clinicians to screen for heart disease in women during pregnancy, during their routine health visits?
So great question, Kelsey. So as far as during pregnancy, kudos. I know blood pressure is being monitored during pregnancy. We talked about as far as the preeclampsia, late second, into third trimester. And I definitely appreciate, I know there's quite a bit of a movement going on, especially also postpartum, that immediate postpartum time. A lot of time what we're beginning to realize is that blood pressure specifically, which is the major factor that we're addressing as far as heart disease related risk during pregnancy, there's been a lot of a push now as far as monitoring blood pressure, even at home after discharge postpartum. Mm-hmm. Now, as of right now, it's not recommended that pregnant women undergo a major heart disease screening during pregnancy, unless, of course, they have a significant family congenital personal history. And if they already have risk factors, we have worked very closely with our obstetrician team and our advanced practice providers as far as monitoring not just blood pressure, but heart valves and other issues. That goes back to that list that I had regarding heart disease. In general, as far as our pregnant population, though, it is blood pressure. And what we are learning, I'm working with a junior assistant professor actually, and as far as research, and it has to do with the fact that blood pressure fluctuates quite a bit as there's that transition towards delivery, after delivery, postpartum, and we are missing spikes in blood pressure, which are contributing to readmissions, heart failure, strokes, with even in that earlier postpartum time. And so for the general population, as far as pregnancy related for women, advanced imaging and testing for heart disease is not necessarily recommended, again, unless there's specific risks, but it is important to still monitor diabetes for those that have diabetes. We know that statins cannot be used during pregnancy, and certain people have severe triglyceride issues. Those are isolated cases that we follow closely between our heart and obstetrics community.
Right.
But for all women, really monitoring that blood pressure and transitioning them back as far as the heart healthy lifestyle, even with the craziness of being a new mom, is all very important.
Yeah. There's a couple, the questions are coming in. So there's a very lively crew today.
Great.
Lynette's got a question, and I'll leave it to you to figure out how to answer it. So she says, can you speak about calcification outside of thoracic abdominal artery? How is it treated or neglected when seen in women?
That is a great question, and we might actually have to need to do a whole webinar about that. So you and I can talk about that, Selena. I know that we definitely have an interest here at our Lynn Women's Institute, and you know, actually, spoiler alert for a future talk, we're even looking at calcium on the mammograms as far as in breast arteries. So yes, it exists. Yes, it's a risk factor. There are ways we can tackle it. And how about if we say stay tuned and maybe we've got a topic.
Great. Thanks, Lynette. Thanks for that idea for a session in the future.
Yes.
Nancy is asking, I've heard that people who take anticoagulants, Plavix, etc., may not be as prone to COVID-19. Is there any research to confirm or support that?
It's a great question. And there are a lot of what we call observational studies that are going on right now. So we do not have enough research to confirm that relationship. You may have heard things as far as anti-inflammatory medications, NSAIDs, and a lot of different, what's going on right now in the field is that they're looking at various relationships. Mm-hmm. And Plavix is a type of, or clopidogrel is the generic name, is a type of medication that decreases the risk as far as what we call platelets or cells that come together. It can usually be prescribed for people who've had heart stents or certain blockages or plaque in various arteries. Mm-hmm. That is not a reason for anyone to take it outside of those indications. We do not have enough data for people to go out and request the medication. It was based upon the fact that in severe presentations of COVID, there were blood clots that were seen. But the answer is no, we do not have sufficient research or information. I give kudos to the scientists and research community that are just trying to look at relationships and help us learn about the condition. But please don't start or recommend that to anyone at this time yet.
Right. So again, watch the science is the answer.
Exactly.
And I know that that you cardiologists are really looking at that interface between COVID and heart disease. It'd be great if you can just take a minute to talk about that and the fact that the science is ever evolving. And I think for those of us who are not doctors, we think science is sort of, static. And so I love this, it's kind of, nerve-wracking, but exciting at the same time that this is real-time science. So if you can talk a little bit about cardiology and COVID in that sense, would be great.
So I'm going to actually start by answering that and just looking at cardiology. The field of cardiology has changed immensely over 10 years, 12 years, 5 years. I mean, it continues to change, and that is one field of medicine. Yeah. Unfortunately, with COVID-19, it is new to the world as far as this particular strain that we're looking at. Yes. And so although forms of the coronavirus have been out in the communities and around the world historically, coronavirus 2019, COVID-19 is new and welcome into the world of science and medicine as we, have to read the literature, distill it, even knowing what populations are even being studied. Yeah. And this will be true as far as we look ahead to other treatment options that are gradually surfacing is who was included, who was studied, were a sufficient number of women included? When we talk about, as us as women and what's appropriate treatments for us, were race and other race and ethnic minorities included as far as a diverse population, geographic variation. And so I definitely can understand that for the public at large, it can be very challenging to hear one thing one day and something else. And that is actually how the literature happens. And how science grows and we're learning from each other. So for people who've known me for quite a bit of time, I've worn a scientist hat and a physician hat. And so I'm watching these worlds really exchange. And as we, learn, and just myself learning about the virus and then also caring for patients. I do want to highlight though, is that the clinics are, as far as health systems, are open. And so please do not be afraid to seek care if you're having symptoms of chest discomfort, there's concerns about heart attack or stroke. Do not delay care because of COVID. Do not try and treat yourself if you're thinking you may be having heart or stroke symptoms. Unfortunately, we're seeing much more, many more heart deaths and heart events for people who may have waited a little bit too late. So yes, there's a lot of science going on and concerns about it, but please don't forget the importance of time as far as early care for heart and stroke.
Right, that's a great reminder. We should always have that every time we have a webinar, I feel, just to reinforce that important message. So Beverly has a question. Is there a genetic component to high blood pressure in the Black population?
It's a great question. The answer is yes, there is. And we talk about a genetic component, environmental component, and the literature keeps rising as far as it's not just one particular gene. I know there are different genetic tests that are out there that can say if you're predisposed to developing it. But we know that a family history of high blood pressure runs a bit more consistently within the Black or African American community. There's also been discussion regarding, salt sensitivity, and the American Heart Association made it very clear that everyone should be reducing and cutting their salt, so not just one race or ethnicity over others. But it does not define the only reason as far as high blood pressure. Same thing with heart disease. We can have family history of heart disease in the family. We know that many other factors play a role, and still many of those things, such as high blood pressure, heart disease, can be treated even with great lifestyle modification and changes, even if there is a genetic or family history component there. Right. So it's just one particular factor. I always tell people, don't think that, your path is set just because of your family history. Just know that you can learn from that, but then how do you bring everything else together as far as treatment and self-care for yourself?
Right. And then one last question, does this lipidemia affect certain ethnicities more than others?
So there are different forms of dyslipidemia. That's a really good question. There are different forms of it. And I can tell you that actually for Asian Americans, there has been a major factor as far as how dyslipidemia can be more of a risk factor for heart disease compared to, for example, high blood pressure. We know that some people have low good cholesterol, even though everything else is at pretty much optimal levels, but that can still play a role as far as a risk factor for heart disease. And so there are various forms. It is important to have at least a basic cholesterol, fasting cholesterol panel. The guidelines then talk about how frequently that should be evaluated, but that's part of that discussion. Sometimes there's specialized cholesterol tests, but we have to, again, put it into context that some people have types of dyslipidemia or cholesterol abnormalities that are more dangerous to their blood vessels. Okay. So not everyone has the exact number they have to achieve when we talk about bad cholesterol levels. It is individualized based upon whether or not you have a history of heart disease and other risk factors. And that's definitely something we discuss in great detail.
Okay. Thank you so much, Dr. Johnson.
That pleasure.
Questions. I want to thank our participants for the excellent questions that they brought to the table. Yes. I feel like we've just gotten this conversation going, and you will please be certain to look out for further topics that are along these lines. Before we go, I want to say thank you also to our sponsors who have made all of this possible. We are going to continue the series further to make sure that we are continuing to meet the needs of women heart champions and women with heart disease across the U.S. Thank you for your participation and have a good afternoon.